Hello, welcome to week 5 content session. This is for NU 621 Advanced Pathophysiology. My name is Dr. Christy Burks. We're going to go ahead and get started. These are just a few of the topics that we're going to cover this week, looking at the musculoskeletal system. And we are going to begin with just going over just an overview of the musculoskeletal system, which we know is very complex. And according to our textbook, Rogers 2023, we know that when we age, we lose bone mass. And unfortunately, especially women, who tend to lose on average about 50%, which leads to issues with deformity, pain, stiffness, and unfortunately increases higher risks for fractures. Now, thinking of other reasons or of the reasons age related bone loss occurs in women, it could be genetics or the hormonal factors, such as that decreased estrogen levels. It could be decreased bone formation, vitamin deficiencies such as that vitamin D, magnesium, and even calcium. But there could also be underlying causes or conditions such as malignancies, those autoimmune diseases, and even things like hyperthyroidism. Other things that can impact it are lifestyle choices such as smoking, alcohol intake, limited physical activity. And then our men's peak bone mass is related more to their race, heredity, hormonal factors such as testosterone, physical activity, and then calcium intake during their childhood. Now, as we age, height is lost due to that intervertebral disc degeneration as well. Now, when we age, our joints and our muscles age with us. So, joints decrease in that range of motion related to those ligaments and muscle changes. And changes in our collagen also can cause calcification and muscle stiffness. Now, skeletal muscle function is dependent on things which unfortunately are affected by aging, including the pardon me, including the nervous and vascular, and then even endocrine systems as well. Now, the textbook does go over some interesting facts, and I thought I'd include it here, but it talks about 50% or approximately by 50. Sorry, let me rephrase this. By 50, approximately 10% of the muscle area is lost, and our muscle strength declines by 15% per decade in the 60s and 70s. And then that doubles to 30% after the age of 80. So I thought that was a very interesting statistics when you think about that. Now, this week, we're going to look at several different disease processes that impact or involve the musculoskeletal system. And the first thing we're going to look at is gout. Now, looking at gout and the progression of gout and how it occurs in stages, Figure 4433 reviews that gout disease progression. And then in Figure 4434, it's an X-ray demonstrating that bone destruction of the first metatarsal because of gout. And you can kind of see the arrow pointing to the bone destruction. Now, looking or talking about the stages of progression of gout, and we know that the first stage is asymptomatic hyperuricemia. And in this stage, excess uric acid builds up in the body, and that's elevating the levels without causing any symptoms. In the second stage, we go to the acute gouty arthritis. And this is the symptomatic stage, and those MSU crystals deposits into the joints. And these crystals are recognized as foreign bodies by the immune system, and that's what leads to the activation of those neutrophils and release the primary inflammatory mediators responsible for that inflammatory response, such as interleukin 1B. And this is what triggers that inflammatory response, which occurs and that leads to that sudden onset of joint inflammation, pain, swelling, redness, and warmth, often affecting that big toe or the first toe or first metatarsal. After this acute attack resolves, the patient then enters what we call the intercritical period. And the intercritical period stage is the periods between the acute attacks when the patient is asymptomatic and those attacks that cause those symptoms. Now, however, our hyperuricemia still persists in this stage as well. The fourth stage goes into the chronic tophaceous gout, which we see the reoccurrence of attacks and the uric acid crystal deposits into tissues, forming tophi, and those are those lumps under the skin. This can cause the joint deformity and even lead to kidney stones. In the last stage or progression, we have chronic gouty arthritis, and this is persistent inflammation and joint damage from the tophi, and this leads to that chronic pain and even disability if left untreated. Now, the progression can be slowed or even halted with the proper treatment to help lower the uric acid levels and prevent those further crystal deposits. So remember, the primary cause of gout is that hyperuricemia, which leads to an excessive amount of uric acid in the blood. And that hyperuricemia can result from overproduction of uric acid, decreased excretion of uric acid, or a combination of both factors. So when uric acid levels become too high, those crystals deposit into those joints and soft tissues. And that's, again, what triggers the inflammatory response characteristic of gout attacks. The diagnostic tests that we look at for gout include blood tests to measure the serum uric acid levels. We can analyze joint fluid to detect those crystals. And then, of course, imaging like ultrasound or x-rays to look for the joint damage or those tophi, the tophi or the joint damage, either one. And you can see the figure 4434. That's a prime example of an image. Now, there are some complications, which we know, as we talked about the disfiguring lumps, the joint damage, but kidney stones can also be a complication of gout. And that's because the uric acid crystals can form stones in the kidneys or the urinary tract. It can also lead to chronic kidney disease. Long-standing high uric acid levels may impair kidney function over time. It does increase the risk of heart disease and hypertension. So gout is associated with other metabolic conditions like obesity and hyperlipidemia as well. So it's important and for that proper treatment to help lower the uric acid levels and prevent those acute flares to help avoid these serious complications of uncontrolled gout. Now, next we're going to talk and look at myopathy and specifically go into toxic myopathy. I do have figure 4312 here. This just shows you the skeletal muscles of the body and it gives you both the anterior and posterior view. So that way, as we discuss myopathy and more specifically toxic myopathy, you can refer to the muscle picture here just to kind of show you what muscles might be impacted. Now, myopathy is a process impacting the muscles and cause the loss of functional muscle cells. And this impacts muscle strength, tone, and even bulk. There are certain agents that we know can cause or lead to toxic myopathy. So medications like corticosteroids, phenytonin, just to name a few, and then alcohol is another. We have contributing agents like our lipid lowering agents, opioids, and even heroin can lead to toxic myopathy. Now, I didn't have this image here, but if you refer to box 44.8, it kind of goes over a little bit more. Now, there are additional disorders that can lead to issues with toxic myopathy as well. And things like your endocrine disorders like Addison's, Cushing's, and even hypo or hyperthyroidism can lead to toxic myopathy. Certain infectious diseases can lead to it, like HIV, Lyme disease, and even influenza. So we're going to concentrate more on the effects of alcohol and it being the cause of toxic myopathy in our discussion today. So the direct toxic effects of alcohol on muscle cells plays a huge role, and alcohol impairs muscle protein synthesis. It increases oxidative stress and that mitochondrial dysfunction within the muscle fibers. And then finally, it disrupts the electrolyte balance, all of which contribute to muscle injury, weakness, and that atrophy. So nutritional deficiencies from chronic alcohol abuse can exacerbate the condition, but the primary insult is the direct toxic effects of the alcohol on the skeletal muscle. So remember, the most common cause of toxic myopathy is that chronic alcohol abuse. Alcohol, again, is that alcohol is directly toxic to those muscle fibers, and that is what causes muscle injury, weakness, and wasting over time. Now, symptoms of alcoholic myopathy or toxic alcoholic myopathy include that progressive muscle weakness, the cramps, muscle tenderness, and difficulty with activities like climbing stairs or getting up from a seated position. And then severe cases can actually lead to respiratory muscle weakness as well. Some of the diagnostic tests that we look at to evaluate this include serum creatinine levels, and that helps we see elevated in muscle injury, electromyography to assess muscle fiber function, and a muscle biopsy to evaluate for necrosis or inflammation. And then ruling out other causes like nutritional deficiencies is important as well. Now, there are other risk factors for toxic myopathy or that muscle damage. So, especially from medications like statins, but some of the other risk factors include the age over 65. We talked about hypothyroidism, renal insufficiency, drug interactions, the high statin doses, and then concomitant use of certain medications like fibrates. So you should instruct your patients to report any type of muscle pain, weakness, dark urine, which unfortunately could indicate rhabdomyolysis, which we'll talk about in a little bit, which is that severe muscle breakdown. But you want to see that early recognition. And so that way, those medications that are offending or causing this could be discontinued quickly to help prevent or reduce those complications like acute kidney injury or leading to worse complications. So making sure that your patients know what symptoms to look out for and how quickly to report those. Next, we're going to go into some bone diseases, starting with degenerative disc disease. And we know it is a condition where the intervertebral discs of the spine gradually deteriorate over time. And the pathophysiology involves the loss of proteoglycans and water content in the nucleus pulpus. And that leads to the desiccation and reduced disc height. Now, the annulus fibrosus also weakens and increasing susceptibility to those tears and herniations. So basically, disc degeneration typically begins with that loss of proteoglycans in the nucleus pulpus and that dehydration. So the primary mechanism of pain in degenerative disc disease is the inflammation of the spinal nerves caused by disc herniation or the bulging of discs and or the degenerative discs impinging on those nerve roots or spinal cords. You can see in the image here, figure 18.17, it's an image of an MRI of the lumbar spine, which shows the disc bulge if you look at the arrow, and then the arrowheads is showing the protrusion, and then the double arrowhead is showing the herniation. Now, the lumbar spine is the body part that is most affected, particularly in the L4, L5, and the L5S1 discs due to the increased mechanical stress. However, degenerative disc disease can also affect the cervical and even the thoracic spine as well. Your risk factors include aging, genetics, repetitive spinal load. You've got trauma that can occur that increases the risk, obesity, and smoking. Now, clinical manifestations range from asymptomatic to chronic low back pain, that nerve root compression, the spinal stenosis, and even decreased mobility. So the pain often worsens with activity and improves with rest. The pain associated with degenerative disc disease arises from that mechanical stress, inflammation, and that nerve compression. So as discs degenerate, they lose the height and structural integrity, and that's what leads to the abnormal loading and microtrauma to the surrounding structures like the facet joints, muscles, and nerve roots. Disc herniation can actually directly compress nerve roots, causing radicular pain that radiates into the extremities as well. Now let's look and compare and contrast osteoarthritis versus rheumatoid arthritis. Now in figure 44.25, it reflects an image of osteoarthritis. And we know osteoarthritis is an age-related inflammatory joint disease that is also a degenerative joint disease, which is mechanical. So it causes inflammation of the synovial joints where there's a loss of articular cartilage or degradation of cartilage, the remodeling of bone, and sclerosis of underlying bone, and even that formation of bone spurs or osteophytes, which can cause those deformities. In osteoarthritis, the protein degrading enzyme, which is the stromycin, is commonly unregulated, contributing to the breakdown of that articular cartilage matrix. And that leads to cartilage erosion and that joint space narrowing over time. Now, MMPs, such as stromycin, are enzymes that break down the cartilage matrix in osteoarthritis. So, the changes that occur in the subchondral bone in osteoarthritis is increased thickness from those bone spurs or the formation of osteophytes and the development of cysts and sclerosis. And in this image for 4431 from the textbook, you can see the ossification and deformity of the joint and erosion of the cartilage and the nodes that formed by osteoarthritis. Oh, this is not the right one. That is the rheumatoid arthritis. I apologize, but it shows that deformity and the erosion, which we're going to go into in just a minute. I do want to talk really quick about the main risks of developing osteoarthritis, and that includes increased age. It's more common in older adults as that cartilage wears down over time. Unfortunately, obesity, that excess weight puts more stress on weight-bearing joints like your knees and hips. Joint injuries. Joint injuries from sports or accidents or trauma can increase osteoarthritis risks for later in life. Genetics can play a big part. Unfortunately, women are more prone to osteoarthritis, especially after menopause. Bone deformities, so malformed joints or defects, increase stress and wear. And then occupation, so jobs with repetitive stress on particularly joints raise osteoarthritis risks as well. But again, the most common causes of osteoarthritis is that aging, that wear and tear on the joints over many years. Now, the secondary cause include previous joint injuries, like we talked about in the obesity, genetic factors, and the underlying metabolic or bone disorders. Some of the main common sites that we see this occur in is the hips and hands. So clinical manifestations include that joint enlargement, pain, stiffness, limited motion, or deformity. And then your treatment includes rest of the impacted joint to help inflammation subside. Aerobic exercise is good, range of motion exercise. Sometimes the use of assistive devices such as cane, braces, and walkers are needed. Weight loss is encouraged, balanced diet, and analgesics like anti-inflammatory drugs can help with the pain as well. Now, other treatments are listed in the textbook and the supplemental PowerPoints, so make sure you review that and think about our population that is dealing with this and other comorbidities and even polypharmacy that may impact, for example, them to take anti-inflammatory drugs. There's a population of patients that are unable to take those because actually a couple of populations just coming to mind. You've got your chronic kidney disease patients. You've got your patients that are anticoagulated that are contraindicated with anti-inflammatory drugs. You've got your patients that have a history of peptic ulcer disease or GI bleeds that we would not recommend taking anti-inflammatory drugs. So think about those things too as well. Now I'm going to get to talking about rheumatoid arthritis, which this image in 4431 is showing rheumatoid arthritis of the hands. And so as we talk about that, look at that. This shows the rheumatoid arthritis. Let me back up, which is an autoimmune disorder, and the immune system mistakenly attacks the body's own joint tissues. So our exact trigger is not really known, so it's idiopathic, but genetic and environmental factors likely play a role in this disease process. In rheumatoid arthritis, the immune system produces autoantibodies like rheumatoid factor and anti-cryptolinated protein antibodies that target the synovial membrane lining in the joints. And this leads to chronic inflammation with inflammatory cells like the lymphocytes and macrophages accumulating in the synovium. And then the inflamed synovium releases enzymes that degrade and erode the cartilage and bone within the joint. So you can kind of see what happens in the deformity in this image. The cytokine that is primarily involved in driving this inflammation within the joints in rheumatoid arthritis is that TNFA, or that tumor necrosis factor alpha. TNFA plays a central role in the inflammatory process in the joint destruction. So the immune cells that play the key role in the pathophysiology of RA are those T cells, B cells, and the macrophages. And these cells infiltrate the synovial membrane, leading to that inflammation and that pannus formation and subsequently the joint damage. Rheumatoid arthritis begins with the clinical manifestations of inflammation. So such as like fever and fatigue and weight loss, weakness, and even anorexia. These joints and or generalized aching and stiffness occurs as well. Now, over time, this results in joint damage, that pain, stiffness, and the loss of function. And that is the image that we're seeing here in 4431, which is showing the damage in the hands from rheumatoid arthritis. The joints can appear swollen. They can feel warm due to the inflamed tissue. The skin over the joints can actually look ruddy or red in color or cyanotic hue, which is that bluish purplish color, and then thin and shiny skin. Additionally, this can cause systemic effects like fatigue, anemia, and inflammation of the in organs like the lungs and even the heart. All right, I think I have one. This is the other image I wanted to show you, which is figure 4430, which shows you the rheumatoid arthritis. Um, and it shows you the damage on the top picture, and A, just showing you the joint lesions, and then B shows you the image from involving the femur, and you can see the breakdown, which is pretty severe. All right. Next, we are going to go over osteomyelitis. And in figure 4418, it shows the states of osteomyelitis. In osteomyelitis, it leads to bone necrosis through the following process. So the invading pathogen provokes an intense inflammatory response, and then this causes a vascular engorgement or edema and small blood vessels thrombosis. The thrombosed vessels disrupt blood flow to the bone, and that deprives it of the blood supply and leads to necrosis or death of the infected bone area. Now, this forms a sequestrum, and the primary pathogen associated with osteomyelitis in adults is Staphylococcus aureus. So, treatment can include antibiotics, unfortunately, surgery if it was like a total hip or a total knee, if hardware is involved, they have to remove that hardware. Incision and drainage with these patients, hopefully to remove the infection or affected areas to save the bone or save the limb. And the use of hyperbaric oxygen therapy is also utilized. Now, risk factors for osteomyelitis include open fractures or bone surgery, endocrine disorders like diabetes, peripheral vascular disease, because you think of the blood flow and the lack of circulation. Our patients that are using IV drug use are more at risk, and then immunocompromised patients can be a higher risk for osteomyelitis. Some of the common clinical manifestations include localized bone pain that worsens with movement, fever, chills, swelling, redness, and warmth over that affected area, drainage from a wound near the bone, limited range of motion, fatigue, malaise, and then in chronic cases, that intermittent symptoms or lack of systemic signs can be present. Now, the pain occurs due to that inflammation and that increased pressure within the bone and potentially the nerve compression as well. So, early diagnosis and treatment is very important to help prevent chronic conditions or complications from chronic infection or pathological fractures as well. Thinking of additional complications, let's look at, I think I have a figure 4419, and it shows a resected femur showing a draining osteomyelitis. So, osteomyelitis unfortunately can lead to amputation and even sepsis. And then we're going to get into, so this can be very severe, and this is unfortunately people can deal with osteomyelitis throughout. It can be very painful, but it's also can be very recurrent if they're unable to get it healed or get things under control if there's a secondary cause. Now, the next disease process we're going to look at is Paget disease. And Paget disease is the second most common bone disease after osteoporosis, according to the textbook. Now, marked by an increase metabolic activity in the bone characterized by abnormal and excessive bone reabsorption and formation or that remodeling. So, primarily, it affects the cortical bone structure, that outer layer of the bone, and that leads to the disorganizing bone remodeling or thickening of the cortices and increased risk for deformities and fractures. So, the trabecular or the spongy bone is primarily affected in Paget's disease, and the disease begins with the excessive reabsorption of trabecular bone, and followed by the formation of disorganized or weakened new bone. This accelerated and abnormal bone remodeling process leads to bone deformities, fragility, and even an increased risk of fractures. Now, genetic factors associated with an increased risk of developing Paget disease include the mutations in the SQSTM1 gene, which is involved in regulating osteoclast function. So, the main risk factors for Paget disease include the increasing age. So, more common in over 55 years old. Unfortunately, males are more at risk. And then a family history or genetic factors play a part in that increased risk as well. It is also more prevalent in certain geographic regions like Australia, Great Britain, and in North America. Some common clinical manifestations include that bone pain, deformities, fractures, hearing loss, headaches, increased head circumference. However, many cases are very asymptomatic and just discovered incidentally. So complications depend on which bones are affected, but can include arthritis, neurological issues, high output heart failure, and increased osteosarcoma. So individuals with active Paget disease, we see a serum total alkaline phosphate levels that are typically elevated. And then you have abnormal x-ray films of that affected bone. So that is an example of here 44.17. You can see in A, that is showing the picture A is showing the active Paget disease. And then in B, this is the same patient afterwards, and it's showing after it's healed, and you can see the characteristics that it's left with. All right, the next bone disease we're going to look at and talk about is osteomalacia. And in osteomalacia, there's a defect in the bone mineralization, while osteoporosis is the reduction in bone mass and density. So in osteomalacia, the bone matrix, the osteoid, is normal, but it fails to mineralize properly due to the deficiency of calcium and phosphate. So this leads to soft, weakened bones susceptible to those fractures. Now, in this first image, it shows the comparison of healthy bones versus osteomalacia. So you can see that. A direct consequence of vitamin D deficiency in osteomalacia is impaired calcium absorption from the intestine. So vitamin D normally enhances calcium absorption. So its deficiency results in low calcium levels in that, preventing proper mineralization of the osteoid, leading to those softening of the bones, which is the osteomalacia. So vitamin D deficiency in osteomalacia leads to that increased PTH levels and hypocalcemia. So the lack of that vitamin D impairs calcium absorption from the intestines, and that's what's causing the hypocalcemia. This triggers increased PTH secretion as a compensatory mechanism to raise the calcium levels, resulting in the secondary hyperparathyroidism. And that is what results in bone pain, muscle weakness, and increased risk of fractures. So adequate vitamin D levels are very important for maintaining that bone health and preventing osteomalacia. Now, the next image from the textbook is 44.3, and it goes over risk factors of osteoporosis. and breaking it down to even to the highest risks for fractures. So when we think about osteoporosis, it's characterized by low bone mineral density caused by altered bone microstructure and leads to that increased risk of fractures as well. Now, the primary pathophysiological mechanism of osteoporosis is an imbalance between the bone reabsorption by osteoclasts and bone formation of osteoblasts. This uh, results in a net loss of bone mass and density over time. So some of our risk factors, and I'll let you read over the rest of them up here in the chapter in the box here. But just being female, unfortunately, is increased risk. Advanced age, you have a low body weight or being small boned, a family history of osteoporosis, low calcium, vitamin D, we talked about estrogen deficiency, especially after menopause. We see that excessive alcohol consumption or sedentary life, smoking. So there's different things like that. And then unfortunately, those higher has the higher risk of fractures, and that includes your advanced age, the prior history to fracture, being female, use of corticosteroids. So think of those populations that are on those medications. So it's important to maintain a healthy diet rich in calcium and vitamin D, regulate the weight bearing exercise, um, to not smoke, and think about those lifestyle changes like limiting alcohol, which can help reduce the risk of developing osteoporosis. Now, this next image in 40, I think it's figure 4411, shows an osteoporotic vertebral bone on the right compared to a normal vertebral bone or body on the left. And you can definitely see the differences. Now, long-term, pardon me, let's talk about long-term glucocorticoid therapy, which contributes to osteoporosis by decreasing the intestinal calcium absorption and increases the renal calcium excretion, impairing bone formation and promoting that bone reabsorption. So there are certain medications that contribute to development of osteoporosis. And unfortunately, if you think about there's a lot of high group of patients that are on these medications. So particularly long-term use of glucocorticoids like corticosteroids like prednisone. So you think of our GI diseases that we just talked about, Crohn's and ulcerative colitis, if they're having having to have steroids, or COPD patients, asthma patients. Other medications include heparin or phenytoin barbiturates and lithium. All of these medications can interfere with that bone formation or increase the bone resorption, leading to that decreased bone density and increased risk of fractures over time. So other substances, unfortunately, include the tobacco, excessive alcohol, which can also negatively impact the bone health and increase osteoporosis risks. We discussed how women are at a higher risk, and that's because women can develop postmenopausal osteoporosis primarily due to that estrogen deficiency after menopause. So if we think about estrogen, how it helps protect the bone by promoting osteoblast, that bone building cell activity, and inhibits the osteoclast, which is that bone reabsorbing cell activity. And after menopause, the drop in estrogen levels leads to that imbalance, favoring the increased bone reabsorption over bone formation, resulting in the accelerated bone loss, and osteoporosis. So, the decline in estrogen also increases our oxidative stress and inflammatory cytokines like that TNFA, and then further contributes to excessive osteoclast activation and bone reabsorption. Now, the textbook does mention how osteoporosis impacts over 200 million people. 79% are over the age of 80. So globally, it causes about 9 million fractures yearly. When we think of fractures and what is involved, the physiological process immediately after that bone fracture is that formation of a hematoma at the fracture site, providing a source of inflammatory cells and the factors that initiate that healing cascade. So when we think of the healing process of fracture, Osteoclasts play a huge role in reabsorbing the old bone at the fracture site to allow new bone formation. So, one of the key roles of osteoclasts during the fracture healing process is the removal of that necrotic and or bone damaged bone tissue at the fracture site. So, this is a necessary to help clear that way for new bone formation by the osteoblast to occur. And osteoclasts reabsorb and break down that old or injured bone matrix so that way through secretion of enzymes and acids. Now we are seeing, it'd be interesting to see if you guys in other areas are seeing, but we are having fragility clinics that are being formed, and this is to help assist with treating and identifying patients with osteoporosis so they can get quicker treatment. Because what happens is a patient falls, breaks their hip, they're diagnosed with osteoporosis, and it was a trauma, so they're on there, but they get a referral to an endocrinologist to get treatment for osteoporosis. But unfortunately, even though we have a number of endocrinologists for the size of our city, the wait list to get in could be months. And so that's delaying treatment by months, if not years. So patients typically are at higher risk to break something else or have another fracture. So we have formed these fragility clinics, which are getting these patients in the next week after they're released from the hospital. So that way they can begin treatment on osteoporosis and start helping that and decreasing their risks for fractures. All right, to go further into the pathophysiology of a fracture, we talked about it a little bit on the past slide here, but injury causes that disruption of the bones, cortex, the periosteum, and surrounding blood vessels, leading to bleeding and hematoma formation between the fractured bone ends and beneath that periosteum. Bone tissue adjacent to the fracture site dies due to the disrupted blood supply. So this dead tissue stimulates the inflammatory response with vasodilation, exudation of plasma and leukocytes, and infiltration of inflammatory cells and growth cells. So within 48 hours, your vascular tissue from surrounding soft tissues and marrow cavity invades that fracture area, and that blood flow to the entire bone increases. The bone forming cells in the periosteum and endosteum and marrow are activated to produce a callus around and between the broken bone ends. And the osteoblasts synthesize a collagen matrix that becomes mineralized. And then lastly, you have the remodeling that occurs when unnecessary callus is reabsorbed and new bone is formed along the lines of stress to align the host bone with tissue. So that healing process is very complex, and it involves both intramembranous and endochondronal bone formation, development of the callus, and eventually the remodeling into that solid bone. So when we're thinking of fractures, there's several different types, so you need to be familiar with it. And in figure 44.1, it kind of goes over different types. So just looking over those. And just to name a few, we've got the oblique, the occult, complete fractures, incomplete fractures. You've got examples of complete fractures. That is when the bone is broken into two or more separate pieces versus that incomplete fractures. The bone is cracked or partially broken, but not all the way through. So examples include that green stick, Torus, or bowing fractures. And then you've got open compound fractures or closed simple fractures, comminuted fractures. So there's fractures can be classified by pattern or direction of the fractal line. So you have transverse versus oblique, spiral, or impacted. So again, take a peek at that. Make sure you understand a little bit further into those. All right, we're going to briefly go over muscle strains, and muscle strain, which involves that overstretching of tearing of muscle fibers or tendons, and the pathophysiology involves that disruption of the muscle fiber structure, that localized vascular damage and inflammatory response. So the cellular process essential for muscle regeneration following a strain injury is satellite cell activation and proliferation. And satellite cells are muscle stem cells that become activated in response to injury and proliferate and then fuse to form new muscle fibers or repair damaged ones. Now we know signs and symptoms of muscle strains can include that swelling, bruising, loss of strength, and even decreased range of motion. Versus we've got sprain, which involves injury to a ligament supporting that joint. So symptoms include joint pain, muscle pain, swelling, stiffness, and bruising. Now, sprains are graded. So you have the grade 1, 2, and 3. So you've got mild, moderate, and severe. So that is important to understand. And in a grade 1, you typically see mild pain, swelling, and slight instability, whereas grade 2 is that moderate pain, swelling, and include partial tearing of the ligament. And then grade 3 is severe, which severe pain, swelling, gross instability, and or dislocation of the joint due to complete tearing or rupture of the supporting ligaments. I had a patient once that had a grade 3 and basically had just torn through all of the ligaments, had just kind of stepped wrong and rolled the ankle and fractured the fifth metatarsal, so it dislocated part of that and fractured that bone. And so when the injury was looked at by the trauma or ER doc, they sent the patient to a podiatrist. So, of course, the podiatrist got them in about 3 or 4 days later, took them to surgery to fix the fifth metatarsal and put a screw in that. And during that surgery is when they identified that that grade of sprain was actually a grade 3, meaning the ankle was just not attached because the ligaments were completely torn. So, unfortunately, this required 3 different surgeries to fix this. So, you think of a sprain as something that's not a bad injury, but it can be. So, things to remember and don't underestimate that. All right, next we're going to look at rhabdomyolysis versus compartment syndrome. So, rhabdomyolysis we know is the breakdown of muscle, which causes that release of the intracellular contents like the protein pigment myoglobin into the extracellular space and bloodstream. Now, the pathophysiological events that cause rhabdomyolysis involve the kidneys and coagulation syndrome and can lead to complications like acute kidney injury. So that release of the myoglobin from damaged muscle can cause obstruction. Remember, we were talking about this in one of the complications of toxic myopathy. But it can cause an obstruction and damage to the renal tubules, impairing the kidney function. And high levels of that creatinine kinase and potassium and phosphorus from muscle breakdown also increase the risk of acute renal failure associated with rhabdomyolysis. Additionally, DIC or disseminated intravascular coagulation and hyperkalemia are also potential complications of rhabdomyolysis as well. Pardon me. Versus the other end, we talk about compartment syndrome, which is the result of that increased pressure within the closed osteofascial muscle compartment, which restricts the blood flow and leads to ischemia and that tissue damage. Now, the increased pressure can result from bleeding, edema, or external compression that compromises the limited space within the non-expandable fascia of the boundaries surrounding the muscle group. So, the clinical manifestations of compartment syndrome are referred to, if you think about the 5 Ps, pain, because it's out of proportion to the injury. So, pallor, that pale appearance, paresthesis, which is that impaired or altered sensations, impaired muscle function, or loss of pulse. Now, the main complication of compartment syndrome, if it's not treated promptly, is very irreversible and it's tissue damage and even disability. So, delayed treatment can lead to that muscle and nerve damage, contracture deformities, and potentially require amputation of that affected limb. Next, we're going to go into bursitis versus tendinopathy, looking first at image 44.8, which illustrates the types of joints throughout the body. So bursitis is the inflammation in the bursal sacs, which, if you remember, bursa are small sacs filled within the synovial fluid and are located between tendons, muscles, and bony prominences. So common sites of bursitis occurs in the shoulder, elbow, hips, knees, and heels. This image in 45:7 shows our elbow and bursa in the acromion, which is the elbow, which is that fluid-filled sac on the back of the elbow at the bony tip. So this acts as a cushion between the bone and tendons and skin. However, when bursitis occurs from that repetitive trauma or overuse, even infection, you may have pain, swelling, redness, and tenderness at this site. Now let's look at an image. Let's see if I still have it on there. Okay, good. Add an image that shows what healthy tendons look like compared to tendinopathy. So when we think about the term tendinopathy, this is a term used to describe tendinitis, tendinosis, and peritendinitis. We know that tendinitis is inflammation of the tendons versus tendinosis, which is that degrading of collagen fibers or disorganized of collagen fibers. Now, the term tendinopathy is that umbrella term that encompasses all of this. So, tendinitis, which again is the acute tendon inflammation, tendinosis, that chronic tendon degeneration, and then peritendinitis, which is that inflammation around the tendon sheath. So, it is all used to describe any painful condition occurring in or around the tendon. The pathophysiological mechanism of tendinopathy involves inflammation and micro tears in the tendon. So inflammatory fluid accumulates, causing swelling and thickening of the tendon sheath, which limits movement and causes pain. So those micro tears lead to bleeding, edema, and pain in the tendon or surrounding structures. With that repeated inflammation, calcium deposits can form, resulting in calcific tendinitis, and the inflammatory exudate that develops after the tendon tear initiates the healing process where the collagen fibers reconnect the torn ends. However, strong muscle contractions during healing can separate the tendons again or the ends again, leading to lengthening or excessive scar tissue, and that actually can impair the tendon function as well. All right. Briefly, we're going to talk about dislocation versus subluxation. So dislocation, we know, is that temporary but complete displacement of the articulating bone ends from its normal position in the joint. This results in a loss of contact between the joint surfaces. In dislocation, the forceful separation of the joint surface can actually tear ligaments, tendons, muscles, nerves, and blood vessels surrounding that joint. The extensive soft tissue trauma can lead to severe pain, swelling, deformity, and potential neurovascular compromise as well. Dislocations often require that reduction to realign the bones and repair damaged structures. But in contrast, we have subluxation. And subluxation involves less severe displacement and soft tissue injury. This is a partial but temporary dislocation where the joint surfaces remain partially in contact. So the joint capsule and ligaments may be stretched or partially torn, but their articulating surfaces maintain some contact. So the subluxations are often self-reducing when the deforming force is removed. However, they can still cause a lot of pain and instability, and and put the joint at risk for that repeated subluxations or complete dislocation as well. All right. There are some bone tumors, main types of bone tumors that we need to talk about or look at. And you have the figure 45.8 that kind of reviews these a little bit. We've got osteogenic tumors, which arise from bone cells or osteoblasts, such as osteoid, osteoma, osteoblastoma, and osteosarcoma. You've got chondronic tumors arising from cartilage cells or chondroblasts, such as osteochondroma. Collagenous tumors arising from fibrous tissue cells that produce collagen, such as fibroma and fibrosarcoma. Myelogenic tumors arising from bone marrow cells, such as the giant cell tumor or Ewing's sarcoma. And then there's other types, including histocytic notochondral and lipogenic and neurogenic tumors originating from different cell lines. Both are benign malignant cancer tumors that can occur in the bones. I'd say that osteosarcoma is the most common malignant bone tumor in children, teenagers, and young adults, which is that osteogenic tumor arising from the bone cells. So benign bone tumors like osteochondroma, um, bone cysts can occur in any age group, but are more prevalent in those children and adolescents. Now, malignant bone tumors that metastasize from other sites are more common in older adults. And then we have the Ewing sarcoma, which is an example of that myelogenic tumor originating from the bone marrow cells, which is also seen in children and young adults as well. All right, the last thing we're going to quickly talk about is malignant hyperthermia. In box 44.1, it talks about critical management, an algorithm for malignant hyperthermia. And the underlying pathophysiological mechanism of malignant hyperthermia is that muscle rigidity, where the uncontrolled and excessive release of calcium from sarcoplasmic reticulum of the skeletal muscle cells. And this is sustained elevation of calcium concentration, which allows that excessive stimulation of muscle contraction and leads to the muscle rigidity. And in malignant hyperthermia, the trigger for the excessive release of calcium from the sarcoplasmic reticulum is the exposure to volatile anesthetic gases or the depolarizing muscle relaxants used in general anesthesia. So, some of the main risk factors include that genetic defect found in people who can develop the malignant hyperthermia, which is the defect of the mutation in the RYR1 gene. So, we want to do a thorough history and talking to your patients before surgery to make sure that there's no risk factors. It is an emergency when this occurs. So, additional risk factors that include muscular disorders. So, thinking of patients with muscular dystrophies, other skeletal muscle abnormalities are at higher risk. Age. So, children and adolescents are more susceptible compared to adults. Family history, because of the genetics that we think of that. Having a close relative who has experienced it increases your risk. So it's important to let the anesthesiologist know this. And then early identification of those at-risk individuals through genetic testing or careful medical history review is why it's so important to help prevent this life-threatening complication, especially during anesthesia administration. All right, I know that was a longer one, but I hope you all have a wonderful week. Please email me if you have any questions. Thank you so much.